Assalamu alaikum wa rahmatullahi wa barakatuh. Inshallah, today, we speak about bronchial asthma, pathophysiology, introduction, and treatment, management approach, and treatment in the emergency department. First of all, I have no conflict of interest regarding this talk. Our agenda, we have introduction, differentiation between intrinsic and extrinsic asthma, how to differentiate between atopy and bronchial hyperresponsiveness, and pathophysiology, hygiene hypothesis, and the role of IgE and eosinophil, pathophysiology of asthma, how to differentiate between different stages of asthma, and assessment of the severe asthma, and differential diagnosis of wheezy chest and treatment approach. Our guideline that we are following for treating bronchial asthma, Global Initiative for Asthma or GINA guideline. Definition of asthma. Asthma is a heterogeneous disease characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, cough, and these symptoms are variable in time and intensity, and there is also variability in the expiratory airflow limitation. So asthma is a heterogeneous disease usually characterized by the chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity with variable expiratory airflow limitation. There are many risk factors that lead to the asthma development. Host factor depend on the genetic factor, gene predisposing to atopy or airway hyperresponsiveness. Obese, they are having a high risk to develop asthma, and female also, they have also a higher risk. Also there is environmental factors like allergen. الالرجين هذه ممكن تكون indoor or outdoor. الانdoor يعني داخل المنزل، الدوميستيك مايتس، الفيرد انيمال، الدوجز والكاتس والمايس، cockroach، and allergen fungi والمولد واليست. وطبعا في هناك برضو اللي هو outdoor اللي هي pollens والفنجاي والمولد واليست. Another environmental factor, infections, recurrent infection of some sort of infection, occupational sensitizer, tobacco smoking, either passive or active, outdoor or indoor air pollution with diet. طبعا we are talking about also asthma is a disease of communication. دائما communication between the physician and the patient, communication of between the patient and his asthma education nurse. Also there is a problem in the communication, that's why the patient's having recurrent attacks of increasing symptoms. It is not a disease of inflammation alone. Asthma, it's described as allergic or non-allergic. Allergic asthma اللي دايما بنحكي عنها extrinsic asthma. Also it is the attacks often triggered by exposure to the substance that cause asthma. وفي non-allergic asthma or intrinsic asthma. The episode is not believed to be triggered by exposure to the substance. Well, allergic asthma, it's sometimes called IgE mediator asthma because associated with high level of immunoglobulin or IgE level. To differentiate between allergic asthma, usually it starts in the childhood and triggered by pollens or animal dander or dust mite. In non-allergic asthma, sometimes triggered by chemicals. The smoker, cigarette smoking, is people those taking aspirin, cleaning agent, stress, laughter, or cold air, or sometimes exercise induced asthma. The burden of asthma في developed economics might expect to spend 1 to 2% of the total healthcare expenditure on asthma. يعني تستخدم ولا يعني ال treatment of management of asthma patient يعني حمل كبير جدا على اللي هي الحكومة والوزارات الصحة. Poorly controlled asthma is expensive. Why asthma still kills? 45% of the patient died without seeking medical assistance or emergency medical care. Out of 195 patients who died due to the asthma, they found that 45 died without seeking medical assistance. 57% were not recorded as being under specialist secondary care supervision. ونصهم تقريبا had a history of a previous asthma hospitalization. و10% they died within 28 days of discharge from the hospital. بالتالي asthma still kill. 1 in every 250 deaths worldwide is secondary to asthma. في دايما سؤال بنسأله اللي هو allergic march. ايش هو allergic march؟ Allergic march اللي هي affecting people from the early stage of their life and continue until their late age, adult ages. Pathophysiology of asthma in 70 كان الاعتقاد السائد إنه this disease is caused by bronchospasm. في الثمانينات they mentioned okay this is maybe secondary to bronchospasm or and plus inflammation. في التسعينات وأواخر التسعينات bronchospasm and inflammation and also there is a remodeling where the present the theory of T helper cell TH and dendritic cell pathophysiology واللي هي يعني الباثوفيسيولوجي في العصر الحديث. So the pathophysiology of asthma it is either airway obstruction, symptoms bronchoconstriction, mucus plug, mucosa because of there is a remodeling, increased vascularity of the bronchial airway, epithelial cell disruption, increased airway smooth muscle mass, hyperplasia, and reticular basement membrane thickening. In addition to the inflammatory cells and infiltration with activation. Atopy, it is at a predisposition toward development of immediate hypersensitivity reaction against common environmental antigen where it is presence of elevated total IgE level. Bronchial airway hyperresponsiveness using quantified using inhalation of increasing concentration. دايما بيكونوا هؤلاء المرضى they have no symptoms at the time of examination or doing spirometer, but when we do challenging test by methacholine or another provoking agent, the fifth one start to be reduced by increasing the level of this material or medication. However, atopy and bronchial hyperresponsiveness both they are not specific to asthma. So atopy mean allergic airway inflammation. Sometimes there is non-allergic airway inflammation. Both of them they will cause bronchial hyperresponsiveness where all of these will result in asthma. It is type 1 hypersensitivity. I mean it is immediate hypersensitivity reaction. Excessive response caused by a large amount of antigen or abnormal heightening of an individual immune state. Severe asthma result in airway remodeling, result in fixed airway obstruction and death. These are the cycle of death in asthma. Pathophysiology, as we see here, the allergen presenting to the antigen presenting cells, the dendritic cells. Then the antigen penetrates beneath the mucosa and enter the lymphatic system. Lymphocyte activation of a Th2 cell, T helper cell, CD4, CD20 state. Th2 release a specific of interleukins and cytokines. These responsible for episodic and chronic allergic reaction. زي ما احنا شايفين they have here interleukin 4, interleukin 13, and Th2 also cell will release of interleukin 5. Interleukin 4 enhance the synthesis of IgE by the antigen stimulated P lymphocyte. Antigen stimulated P lymphocyte or plasma cell will synthesize IgE. IgE will bind to the receptor on the mast cell, result in activation and release of inflammatory mediator زي الهستامين والليوكوترين والبروستاجلاندين والسيتوكاين result in atopic disease. طبعا هذه immediate phase بيحتاج من 15 to 30 minutes. This is called acute allergic response. الانترلوكين 5 زي ما احنا شايفين هنا will play an important role in recruitment of eosinophil to the site of inflammation. Will result also in release of the mediator and result also in a tissue destructive effect. And it is, will be delayed phase بيحتاج من 6 إلى 8 ساعات. أزمة هيجين أو theory بيحكي إنه الناس اللي بيعيشوا في الدول ال developed country دائما بيكون عندهم less exposure to the helminthic infection, to the viral infection, to the pollution. So the T naive cell or Th0 will be produced to the or shifted toward the Th2 response. لكن الناس اللي بيكونوا في developing country with recurrent exposure to the helminthic infection, to the bad environment, result in also switching of Th0 or naive T helper cell to Th1 اللي هي responsible على secretion of أو إنتاج الانترفيرون جاما انترفيرون والليمفوتوكسين. وهذه الباثوفيسيولوجي of our asthma hygiene pathophysiology. المast cell degranulation will result in release of the inflammatory histamine and other leukotrienes, prostanoid, wilkinine. All these are mediator and cell degranulation. All this result in bronchospasm وبلازما exudation, mucus secretion وstructural changes. العيان لما يجي على الطوارئ أو يجي seeking for medical treatment, we will see only the symptoms or just only of the tip of the iceberg, while there is airway obstruction, bronchial hyperresponsiveness, or airway inflammation. Protective factor for asthma. They mention being younger, sibling, البيرث nursing, الناس اللي breastfeeding، الأطفال اللي بياخدوا good breastfeeding، living farm living، agriculture، sometimes protective factor، exercise، healthy diet، low pollution rates في environment. والعكس تماما الناس اللي بيكون عندهم other high risk factor to develop asthma. هنا cut section of bronchial airway in asthmatic control where a patient with fatal asthma, as we see here, there is a mucus plug وهن submucosal gland hypertrophy where basement membrane thickening وepithelial cell remodeling. So there is epithelial damage, basement membrane thickening, airway smooth muscle layer, is thickened also. As we see here also, patient with a small airway, there is narrowing and of the bronchial airway diameter. In a postpartum appearance, after removal of the lung outside, the lung is hyperinflated and the lung didn't collapse on the opening the thoracic cage because of hyperinflation. In a cross section of the large cartilaginous bronchus filled with very viscous mucus plug. So we will diagnose patient with bronchial asthma. Patient usually present with respiratory symptoms and typical of asthma. Detailed history examination and support asthma if it is okay. We will perform spirometer or peak expiratory flow with reversibility test. If the results support asthma diagnosis, we'll start to treat the asthma. If the detailed history examination and not support the asthma, so we'll check for further history and test for alternative diagnosis. And sometimes the asthma is not clear from the start. We can repeat the test of asthma with sometimes a provocation test or asthma challenging test. And we can also start empiric treatment with ICS and PRN, per request and need, short-acting beta agonist will review the response and diagnostic test within 1 to 3 months. Diagnosis also increase the probability if there is more than one symptoms, wheeze, or shortness of breath, or dry cough, or chest tightness. If the patient having isolated cough with no other symptoms, or production of sputum, or shortness of breath with dizziness or lightheadedness, chest pain, exercise بدنا نفكر في أشياء ثانية غير البرونكيال أزمة. How to confirm؟ نعمل اللي هو spirometer. السبيروميتر بيعمل لنا بيعطينا قراءة الفيف forced expiratory volume in first second على forced vital capacity وبتكون الريشيو reduced less than 70 and a reduction of each parameter less than 80% of predicted. And should be also there is a variability, that means after giving the patient salbutamol or a bronchodilator there is increment or increase in more than 12% of the FIV1 before bronchodilator and after a bronchodilator. I mean increment of FIV1 more than 200 ml. زي ما احنا شايفين هنا الفلو فوليوم لوب. Flow volume loop, this is the inspiratory loop and this is the expiratory loop. The patient is having scalloping of the expiratory loop. بالأحمر there is a scalloping or limitation of the forced expiratory volume in the first second. After 30 minutes bronchodilator, the patient improved almost more than 12% أو أكثر من 200 ml. That means this patient is having reversibility test positive and it support the diagnosis of a bronchial asthma. ونفس الدياجرام اللي موجود هنا اللي هو volume time diagram or graph. How to assess the patient is controlled or not. And the 4 questions very important. Daytime asthma symptoms more than twice a week. Any night awakening due to the asthma. Reliever need for symptoms. How many times he's using reliever? More than twice a week. Any activity limitation due to the asthma. Either none of these symptoms, the patient is well controlled. 1 to 2 of these symptoms partially controlled with a can. 3 to 4 of these, this patient is not controlled. Assess, adjust and review. دائما في follow up treating the controlled symptoms and minimize the risk. دائما assess the symptoms controlled plus the risk factor, adjust the treatment pharmacological and non-pharmacological and review the response. The controlled the control-based asthma management, diagnosis and asthma symptoms, control, risk factor including lung function, inhaler technique very important. لازم نسأل برضو في كل زيارة عن ال adherence to the patient to the medication, pharmacological, non-pharmacological, which medication, how this patient is using, all this stuff, and also the symptoms, exacerbation with side effect, with patient satisfaction, with lung function every 3 months. طبعا في there is a steps approach for treatment of bronchial asthma. في عندنا step 1, step 2, step 3, step 4 and step 5. Usually الميديكيشن تتراوح طبعا this is according to the GINA guideline in 2020 في عندنا 2 arms of treatment, preferred controller and preferred reliever. دايما عندنا في reliever وفي عندنا controller. الكنترولر اللي هو دايما ICS أو inhaled corticosteroid، والريليفر either short acting beta agonist or long acting beta agonist. وبالتالي step 1 as needed low dose ICS formoterol، يعني as needed عند الحاجة low dose of ICS inhaled corticosteroid مع الفورمترول. الفورمترول هو لابا أو long acting beta agonist. or another controller ممكن low dose ICS taken whenever SABA is taken، يعني ممكن برضو ناخد اللي هو low dose ICS و short acting beta agonist هذا في الستيب 1. والريليفر دايما as needed low dose ICS formoterol. Step 2 we can do a daily low dose inhaled corticosteroid or as needed low dose ICS مع الفورمترول، وممكن نضيف بعديها مع اللي هو daily leukotriene receptor antagonist or low dose ICS taken whenever SABA is taken. طبعا هنا في اللو دوز اللي هو daily leukotriene receptor antagonist زي اللوكاست المونتيلوكاست. Step 3 بنعطي low dose ICS مع الكومباينيشن مع اللابا or medium dose of ICS with low dose or low dose inhaled corticosteroid plus leukotriene receptor antagonist. Step 4 medium dose ICS with LABA. Step 5 high dose ICS with LABA. Sometimes we can refer to the phenotypic assessment، يعني نعرف ايش الphenotypes of a bronchial asthma. There are different phenotype. We can add on therapy. ممكن نضيف تيتروبيوم اللي هو لاما long acting antimuscarinic اللي هو تيتروبيوم. ممكن نضيف اللي هو biological agent زي ما احنا عارفين اللي هو الانتي اي جي اي ليفل زي ما احنا شفنا في الباثوفيسيولوجي. انتي اي جي اي اللي هو الزولير or اوماليزوماب or انتي انترلوكين 5 زي الريسليزوماب or انتي انترلوكين 4 زي اللي بتعمل بلوك للانترلوكين 5 الدوبيليوماب. With the preferred reliever always as needed low dose ICS with formoterol or as needed short acting beta agonist هذا عند اللزوم as other option. دائما assess confirm the diagnosis, symptoms control with modified you can modify if you can modify the risk factor and check for comorbidity inhaler technique والadherence والpatient preference دايما مهمة. treatment if the patient symptoms less than twice a month you can start with a step 1. If the symptoms twice a month or more but less than daily you can start from step 2. If the symptoms most of the day waking the asthma at the night once a week or more, step 3. If the symptoms most of the day and awakening this asthma once a week or more or low lung function, start from step 4. طبعا هنا هذا الدياجرام بيعطينا كيف نفرق بين إن لو بالنسبة لللو دوز والميديوم دوز والهاي دوز regarding ICS or inhaled corticosteroid. طبعا حكينا هذا برضو اللي هو step 5 when to add for the التيتروبيوم والأوماليزوماب والميبوليزوماب for severe eosinophilic asthma. وstep down from low dose. طبعا كل every 2 to 3 months we have to either step up or step down according to the patient situation. ممكن برضو to consider اللي هو slit therapy or sublingual immunotherapy and how dust mite sensitize and in the patient with having house dust mite sensitization in the skin break testing. to avoid الالرجين بعد ما نعمل السكين تيستينج to assess the sensitivity for potential indoor allergen. هذا how you can conduct the skin prick test and check which the patient is having a large wheal and the patient to advise the patient to avoid the trigger allergen. ممكن تكون هذه common asthma trigger, must diet, cold, strong smell, والsmoke والweather والcockroach sometimes. All a patient should have a written asthma action plan. The action plan include the patient usual asthma medication and هذا جزء من الأزمة أكشن بلان واعتمد على اللون الأخضر والأصفر والأحمر. الأخضر use this daily control medication اللي هو بتعمل control وإذا patient صار عنده في sign of cold, exposure to unknown trigger, صار عنده cough, mild wheeze, tight chest, coughing at night, the patient we have to go for the yellow and should be medicine ونكتب له الميديسين و how much and when often. لما يوصل الأحمر we have to teach the patient when he can contact his doctor now and to go for the further assessment at the emergency. Asthma action plan is very important ولازم يكون ال patient you know when to go, when to seek for assistance. Flare up or exacerbation, acute severe asthma. طبعا قبل إن هذا في أزمة ميمكس زي ما احنا شايفين هنا الصورة هذه كلهم كلاب هنا لكن في وولف هنا مختبئ بينهم. فبالأزمة كان there is a lot of mimics chronic rhinosinusitis, GERD, recurrent lower respiratory tract infection, cystic fibrosis, congenital anomalies, TB, immunodeficiency, congenital heart disease. All these can mimic the asthma. Differential diagnosis of wheeze. مش كل wheeze is asthma. للأسف في بعض الأطباء دائما يتم التشخيص بناء على السماعة and this is not accurate. Not every wheeze is asthma. COPD اللي هو bronchial obliterans, cystic fibrosis, bronchiectasis for lower airway disease والupper airway trachea or mainstem bronchial tumor foreign body vocal cord dysfunction. Cardiovascular disease الناس اللي عندهم BE congestive heart failure and sometimes carcinoid, Church-Strauss syndrome, cocaine inhalation, allergic bronchopulmonary aspergillosis, differential diagnosis of acute asthmatic attack. Severe asthma defined as a disease is not responsive to the current treatment including symmetric administered corticosteroid. And difficult asthma, failure to achieve the control. Brittle asthma is described patient with severe unstable asthma to who maintain a wide peak expiratory flow variability. يعني بيكون العيان تمام الصبح بعد ساعة ساعتين بيخش في attacks of severe asthma والpeak expiratory flow very variable. هنا ممكن العيان نعطيه اللي هو الجهاز هذا بنسميه peak expiratory flow وبيحدد لنا for the expected age and race and gender which giving us a diagnosis of brittle asthma. near fatal asthma. near fatal asthma طبعا في الطبيعي الإنسان في bronchial asthma you have a normal or low PCO2. once the PCO2 start to raise, this means that the patient is having near fatal asthma and the patient should be admitted to the ICU. Hyperacute fulminant asphyxic asthma, the interval between the onset of symptoms and intubation is less than 3 hours. Flare up والexacerbation طبعا هذه very important definition and terminology. High risk people, if there is hospitalization in the last year, previous ICU admission, recent steroid use, deterioration while he is in a steroid, previous life-threatening attacks, increased CO2, and in the previous history of ICU admission and intubation. هنا هذا البيك flow meter. البيك flow meter are used to measure the peak expiratory flow rate. وهنا how to management of acute severe asthma in adult. طبعا هنا for men وهنا for women ولاش expected peak expiratory flow for each. طبعا تعتمد على الage والهايت من والجندر. Indicator for severe asthma indicator: anxious or diaphoretic appearance, upright position, breathlessness at rest, tachycardia, pulse oximeter less than 91, LbCO2 normal or increased, will peak expiratory flow rate less than 150 liter per minute or less than 50% of the predicted. Severity of acute exacerbation: life-threatening, acute, severe, or moderate, depend on the peak expiratory flow rate and the asthma symptoms, oxygen saturation, if the heart rate sometimes, and also we can assess the severity. In general, acute severe asthma, the patient is tachypneic, tachycardic, there is sometimes arterial paradox, accessory muscle usage, diaphoresis, silent chest, in case of severe asthma, cyanosis, or altered mental status. Level of severity برضو هنا زي ما حكينا mild, moderate, severe, life threatening, and depend also oxygen saturation more than 90 to 95. Here less than 90 the oxygen saturation. The peak expiratory flow more than 50 of a predicted. Here the peak expiratory less than 50. Life threatening, the patient will be drowsy, confused, silent chest, or bradycardia. Aim of treatment: relieve the airflow obstruction, hypoxemia, restore lung function, prevent future relapse, and develop written action plan. Diagnosis حكينا عنه، والassessment and treatment في initial airway طبعا في emergency airway breathing ABC circulation، and في المايلد والمودريت. المايلد والمودريت بيكون بيتكلم في جمل prefer sitting to lying, not agitated, respiratory rate increase but not more than 30، والpulse rate من 100 ل 120، oxygen saturation من 90 ل 95، والpeak expiratory flare more than 50، والsevere is less than 50 predict. Treatment: short-acting beta agonist اللي هو سابا salbutamol, consider sometimes ipratropium bromide or aerovin. Give a patient oxygen saturation, maintain saturation من 93 ل 95. في children والpregnant lady لازم يكون 94 ل 98. You can give also oral corticosteroid for mild or moderate. في severe you can consider also giving IV magnesium sulfate, giving oral or IV corticosteroid. We can consider high dose of ICS. And regarding continuing, as the patient if continue to deteriorate, you can also assess by the ICU and call ICU for consultation. If the patient FIV1 or peak expiratory flow من 60 ل 80 of a predicted, and the patient is improvement of his symptoms, you can consider for discharge planning. if ده كان أقل من 60% predict personal best, this is severe, continue treatment and reassess frequently. ممكن تعطي اللي هو salbutamol nebulization every 20 minutes to assess. في first hour ممكن تعطي up to 3 nebulization. General measures قلنا أكسجين وأنتيبيوتيك. ستاندرد ميجر بيتا أجونست اللي هو بيتا 2 شورت أكتنج زي السالبيتامول. أنتي كولينيرجيك زي الإبراتروبين برومايد. مغنيسيوم سلفيت. and sometimes if nest control ممكن العيان نعمل له mechanical ventilation. sometimes الهيليوكس bind for oxygen supplement عشان يعمل more bronchodilation. Oxygen therapy, we have a special lecture for that, but our target to keep in saturation 93 to 95, لكن في children والpregnant lady 94 to 98. Steroid, bronchoinflammation steroid and bronchoconstriction we give a bronchodilator. طبعا الاي سي اس treat the inflammation. البيشنت دايما احنا ما بنحب نعطي لحاله long acting beta agonist او اللابا. لابا alone will cause the patient increase the reliever use. We will cause sometimes tachyphylaxis of the receptor وبالتالي يؤدي إلى poor outcome. So LABA alone, it is a black box and not recommended to be given alone. لازم ينعطى معها ICS. وهنا هذا ال MDI meter dose inhaler for giving either steroid, inhaled steroid or inhaled bronchodilator. طبعا الأطفال يفضل إنه يعطاهم اللي هو السبيسر لأنهم usually they are unable to يزامنوا بين أخذ الجرعة وأخذ شهيق وبالتالي معظم الدواء concentrate في الحلق which is not the site for treatment. Spacer is very important for elderly and for the people with children. They are unable to use the MDI alone. Can we give also nebulized budesonide in bronchial asthma at the emergency? Yes, rapid effect. Sometimes inhaled steroid budesonide can give rapid effect. في study انتشرت في the rapid effect of inhaled corticosteroid in acute asthma في chest physician, American College of Chest Physician. The effect of nebulized high dose. طبعا الميكانيزم of steroid action في عنا genomic effect اللي هو participating of cellular genome والnon genomic effect برضو هذا other effect of steroid. الجينوميك effect correlate with clinical evidence وبيحتاج من 4 إلى 12 ساعة. وعندنا النون جينوميك effect interaction with the membrane receptor it can have a rapid effect acute vasoconstrictor effect of ICS in the airway. It will inhibit the norepinephrine uptake so increase the neuromuscular junction vasoconstriction and decrease airflow blood flow enhance the action of inhaled bronchodilator. Theophylline, the routine use of theophylline is not recommended. Sometimes the use can be also cautiously in elderly patient or the people they have structural heart disease. Magnesium sulfate dose بتاعته 2 gram IV over 20 minutes diluted in normal saline في biurate. A patient sometimes we have to request for him radiological evaluation. زي ما احنا شايفين هنا sometimes the patient will have acute dyspnea as we see here the lung collapse there is tension pneumothorax that result in acute exacerbation. Follow up after the exacerbation. Patient are increased risk during the recovery from exacerbation. زي ما حكينا المورتاليتي ريت بتكون في أول 28 يوم so we have to give him close monitoring and follow up and asthma action plan. If the patient is a smoker modifiable risk factor to advice to smoking cessation والadherence للmedication check inhaler techniques وasthma action plan. All patients should receive nebulized agonist before presentation. Patient should have also, before discharge, you should have also discharge the patient inhaled steroid. The very important is inhaled steroid rather than LABA alone. Thank you very much.